Una dey well today, ba? My name na Raphael Magin. Today we dey talk with correct people wey dey studio with us today for correct work wey they dey do for we area for communities to help people lives and improve their health. These people na movement for change. We dey call them MOTSI Don Canji. They don dey work for Adamawa, for Bauchi and for Gombe. We will hear wetin they dey do and how e dey affect people and e dey improve their lives.
Mo no na.
That my name na Endurance Jim Rogonu from Adamawa State.
Okay, my name na Anza Samuel from Adamawa State.
My name is Maria, psychologist.
My name is Odia Gave, and I'm an independent human rights activist here to support the movement.
Okay, una dey very well formed.
Thank you.
So this movement for change, how it take starts and why una dey do am?
Okay, movement for change like the name applies. Na community we represent, and all of us get unique problem for the community we dey represent. So we believe say when people come together, they get upper hand to address particular problem, and the problem no go solve am quick if all of them come together. At least they will see that energy say true problem dey. So like I talked before, we be a group of different people decide say okay, both could come together, identify problem we know say it dey bother our community wey we dey represent. So we can't check them, and all of us can't dey northeast. The folk come dey across each other. The state self, look at self, na neighboring state abi. So I can't look for another community wey dey Gombe. We'll talk to each other as we go see the opportunity. We'll talk to them where they Bauchi too. They also at Adamawa. We can discuss together. As we look at, we can discover say all of us get similar problem with the border across each community. Now we say okay, but we form movement. We go bring change. We go benefit our community. We will know say if we push am, it will help us, and that problem we go address her. So now how we come up together, we will form that movement for change.
If so, this movement for change, different people come together.
Different people come together. Different organizations, different people represent different organizations now come together.
Okay. So these organizations, wetin be their name, and wetin be the things wey they do for this movement?
Okay. The organization wey form this consortium na TARA, that is the Alliance for Rights and Health Advancement Initiative. Then we can get HealthPro, that's Helpful Progressive Women Foundation. We have HASKE Youth Initiative.
Total Health Empowerment and Development Initiative.
Yes.
That one might be the other organization with that. So we dey for a number. We actually come together, and all of us they represent different communities, but we get one unique problem.
And the reason why we come together, we say we want identify the challenges and the need where these our people get for health facility, the one-stop shop where we dey call and where our community they free to enter and access help. That's it.
Yeah. And of course the OSS which you just mentioned now, if they across the 3 states, where all of us they work together. That's Society for Family Health. Okay. And our committee members now there they like access services, because for there they believe and they know say whichever problem wey dem get, they it is safe for them to go access those services. So for us, we just know say it get unique problem where we need to work closely with those people and our community members aside of the HIV work. We know say they be only HIV services wey they provide. They be only that one be our community issues. As we be different community like this, all of us get particular services where we would like to be access. So from there now, we bring those, even those OSS people, we work with them. And also we just work with them. We do what they call research. One kind small research. And we will do the research. And we will do for our community too. Now I do this research across those 3 states. So that we actually get the accurate information. You know, can be as if now based on say yes, now they take work. So we do that research and our own people now I still go do that research. So as they do the research finish, then use that information, can't give us as consortiums. Say, now send us, so now what you will get with this, now information will get with this, or you're open to take. And based on that information, what we get, we carry on now. We invite those people. So Yamokuna come across the 3 states, so Yamokuna come. Based on this research we will do now what we discover about this. And with these people, we thought say A and P and G, they available. For instance, mental health services, which some people would like to get, they GBV services where they would like legal support, they, you understand? Post-abortion services where they feel say make it day, they do. So we feel say that OSS they operate suppose they comprehensive based on our target population who they work with. Even harm reduction services, they know they do. Do you understand? So all those services now will come carry them now, tell them. So what we will do be say every on quarterly basis now, we will meet, we could discuss these issues. We could discuss it. We know so issue we address them at once. So for the past 3 months, 9 months rather, we deal with them back to back. We engage them, they educate them, they sensitize them, they try and let them know say, now what thing on board be this, now what thing we want be this, now this is not our problem, how na go take help us, how na go take coming with our community now go get better services. Okay, yes.
I don't do this work for months now.
Over we do it for over 9 months thereabouts.
I wanna start with research.
We start with research because say anything we no get fat. As it be. You go get backup where you feel stand the bank. Just say now for here now we get this information.
It there one big 20 where our sister for here say na one-stop services.
One-stop shop.
One-stop shop. Okay, now they offer those services to people for community.
Yes. That one-stop shop. My sister here, she will. I think she will help us tell us.
Okay, that one
side of it is
that one-stop shop. It be like small hospital, but waiting our study, our research give us say now only HIV they fit treat for that center. But the community where they work with, their problem is not only HIV problem. So that's why we do the what do they call them? Research to identify those challenges that our community people need.
Oh, okay. Okay. This work should be like say they very impactful because for we area and communities, people don't they suffer for HIV, mental health, and all of those things. So which kind work una don't do we touch people well we una ma free share with us? Who know the successes, things una don't help people for these communities achieve? Is there any story where if you share with us?
After this our work where we do, we get one of our community member where can get post-abortion fail. The abortion where she go do can't fail. So they can't carry her go hospital. As she reach the hospital, she can't the nurse come dey ask her plenty question like that, she come find out say see the work wey she dey do wey she gon get the belle. So before that nurse, they go just useless that community person, but because we don already sensitize them, you understand,
Yes.
the person don she know her right, say they must treat her for that hospital too. That one help our community person. They give her the services wey she need at that particular time. So this is a success story for us, because without this our sensitization, she no go know wetin she wan do. She go just hide for her room, and the result no go good.
Okay. So, and again, make I add to what she talk. You know, say before, like I talked earlier, say before we start this work, we do research, Abi, and that's through research too. Now we take work throughout. From there, self, we even do IC development. Now, still part of the research. Now we do that IC development. You understand? So, and that IC development, what we do, it help, one of the success stories, they say, it help increase service intake. Because the IC material, it capture a lot of information. Where services where we know, say, people know they are aware of. Like now, the mental health services, people know they are aware of. But if we look for that IC materials, who they do? It captured inside. The GBV services, people know they are aware of, but it captured inside. The prevention services, like PrEP, PEP, condom use, contraceptives, and waiting, harm reduction, waiting. It dey inside. You understand? So it increase service intake. If you just use that IC material, you go know say, I fit get A and B through that place. And we get the contact of every OSS. Like if you go at Adamama Week, you open that template, that end of the IC material, it dey there. It will show you where you go fit get these services. If you dey Bauchi, no need to call anybody. They go see you, refer you, go for Bauchi. And they again also help the people, the clinic team who will work with for inside OSS. They also help them understand, say, community members need unique services. They first say, I be this person, no me say my services with this my sister who sit down next to me, it did the same. Our own services, they different. And the IC material who also produce, not only talk about that our community members, it also include people with disabilities, with they among our communities, which we know is now one of the cap, with there to they suffer a lot in accessing services with them what. And the thing also reduce stigma and discrimination again, our intervention. So like unlike before now, if you go there and the whole they go they look you, say I need, for instance, I need like post-abortion services. Like oh she talk you go be there for years if where you they come from. But with this intervention now, they work in like I know say yes, policy and waiting, they make people they go do unsafe things. But they don't say they do abortion this thing for the OSS, no. But they're there to save life. If you get harm, boy, you go meet them. Say I beg go, as this why I do this thing, I know they're comfortable again. If even within them, if you don't get the power, they could definitely find way refer you.
Okay.
Yeah. And it also increase all kind of services where you want. You don't need to begin the run like condom like this for instance where you need condom. You don't need to say you want to go the copy people. Just on your own, if you look at our IC materials, you will know say, okay, if I go to so place, they go get this condom where they look for. Man, go run, show away, and run safely. So those are our successes we actually, get throughout this program. And committee members self, the friendliness between people with the OSS or relationship between people with the OSS and our committee members now, at least is it much better compared to waiting it be like before. So our solo stories he plenty, but we know that because of say time said no tables. We believe so you get other questions. But if we both still come back, we share plenty even after our show to here. Thank you very much.
So this work that they do, they affect people. It don't change their mindset to go seek for services, and people when they suffer from those things where before they shame to come and they come out now, go seek for treatment.
Yes.
Okay, so who they help?
And again, the work, say the work also, I'm gonna tell one also success story we've been get during our quarterly engagements or quarterly sensitization and engagement we will do with East OSS. Before, the minute they talk about harm reduction program. But for the next, and this will be even shock us, say, even that they don't write to their donor. And also, donor get restrictions. Yes, maybe every services where you feel say you want to, but for donor side, they don't say no. For this part, no go for now. You understand? But for this our program, at least we don't push. They say they don't push from their own end. Say committee members, so this particular services they need them. So how now want to do? So us we don't push, and they say we believe say they don't push. And when they will come up with the next one, they will tell us good news. Say at least don't they look into them, and for their own side, it will come out positive.
So I want to put that on share with you be that. So now well done for this plenty work going that they do. You go talk and do like Sigma small team work. So who be the donor with the support owner to do this work on that they do?
Okay. I know they don't know, but my sister here, now she know them pass. Now through her, I will know them.
Okay. The people where they support us do this work where they do, nah, their name is Dao.
Is thou.
Yes, sir.
Okay. I will thank is thou.
We thank them very well.
And say, and them did this their main focus now community intervention did it wrong. Yes, they do anything when they get their own community and people where they like actually work with directly. But they don't say solution. Now community get problem. Now community now go still solve problem. Yes.
You talk mental health. Some people na mental health. Some people na HIV. Some na GBV. So from this work we they do, we don't help key populations to come out, come seek for help and get those services where they need. What do you go tell us? Which forms of stigma and discrimination do key populations face in accessing healthcare services?
Okay. Thank you very much. I did happy for the work where this consortium don't do in terms of the successes they don't share. But they speak from my general understanding based on the work pattern they do with key populations over time. And I could also be happy to hear from them also if some of these stigma discrimination issues where I go mention are things where they don't help to achieve also based on the surface where they like implement. But some of the stigma discrimination issues where key populations they experience for healthcare settings, one na judgmental attitudes of the healthcare providers, like where people get like moral policing, like maybe the police for your moral behavior, like this personal behaviors where they engage with this sex work, injecting drugs and other things that you're doing, maybe things where you're supposed to do, and the reason why they face these health challenges we carry you come this facility be this. I think that healthcare providers need to also ensure that their first priority not to ensure say lives are saved, to provide the services where the person come to see cannot really be judgmental and can they ask questions as to why you engage in this activity, why you do this now, why you do this thing. God loves you, you're not supposed to do this kind of thing. So those kind of things can push people further away from their healthcare facilities as well. And some of those judgmental attitudes come off as verbal abuse. Like we've seen cases where people are verbally abused at healthcare settings. I know of somebody with in say income facility to get tested for HIV. After then test them in they positive, then they will look file for them to carry go another segment when go enroll for treatment. Then make notes inside the file, say this person sex worker, so no as you they treat with this person, right? So those kind of things can also in fact affect how people they willing to go access services. Another thing substandard services. I feel like some of the healthcare workers know say just because in a key population you be the quality of service where you get to the day as good as the quality of services that would be given to other people. And sometimes you go just sit down there, they spend time. They wait for when they will call you. Like people, you get other things to do, right? I know say your health is important as well, but you also get other things to do where go affect how you make your money. And people get shocked when they don't even feel leave. Because if you tell your oga say you get HIV or you be key population, you want to go access services, and then you go healthcare service, then they treat you differently, then they waste your time deliberately just because they keep population. Yeah, and sometimes the healthcare providers themselves, they don't even the knowledge around waiting be the issues, the specific issues for key populations. Like it is different to say, so somebody get headache and then you just give everybody paracetamol. When it comes to key population issues, like you need to really dig into the reasons why people are experiencing certain kind of things and know what kind of specific services that you could tailor to the person needs. And so sometimes the healthcare providers don't even get that knowledge at all as per how to even deal with a key population. And so they don't even know how to handle key population's issues. But I feel like some of this work within they do now things where it could help to address some of these issues where key population they face in terms of stigma and discrimination for hospitals or healthcare settings, especially for one-stop shops. And one-stop shops basically in a place where key population suppose see everything and be just about healthcare services like games, community center. I just have everything you need. And so, but sometimes our one-stop shops, they solely focus on the healthcare service provision that they forget the other needs of equal, the needs for community, the needs for community building, and just to create this safe space for everybody to come access services. So yeah, I'm looking forward to hear how this program or this project also help to address some of these issues.
So just like what's in ultimate talk, and I happy say as if say as if we know say na issues where or he go come talk am for here where we did. But funny enough, like he mentioned, stigma and discrimination. I remember as I tell you, say we don't develop IEC materials where we share, and if we look at IEC materials inside, it talk about stigma and discrimination. And if we look at IEC materials, they talk about confidentiality. And if we look the when they talk now things with the withdraw key population to actually come access services, not just for OSSO, even for other health, facilities. And funny enough, will be they able, and the IIC material will be developed. We will not just sit down as consortium, say because we consortium, we could just sit down and do IIC material. We'll be bring them themselves, make them sit down, we could draw them. And as I even happy say Tanbo say as a KP specialist or knowledgeable person. We don't work for years. We concern key population matter. He can even talk yes and the issues where key population they face better. And I did happy say all those things at least we've been there able to capture it in our IC materials. And we believe say as the IC materials they go far, people will read them so they understand. So okay, I even the followers I said we drop for them. I will do some banner who will keep. So like anytime to the worker where you see so they don't give you notice. I don't tell you say A and B and D supposed to for this space. And that issue of confidentiality will be bold as well. Because now some people will know say key population they face, they'll be just OSS, even in other places where they access their services. And we call key population with the like confidentiality where once one person matter don't come out from somewhere, forget her. No go like go there again. So I have been saying also mention those states where you have some and also were they able to capture them for our IC material with the field. Thank you.
Hi, well done. So how do these forms of stigmatization, how do they affect the mental health of key populations and also affect their willingness to seek for services?
No. So thank you so much for your question. And then thank you to the consortium organization for the work you do for key population, what you have done this far.
Thank you.
Yes, so I would like to talk about what mental health is first before we can talk about how it affects the key population generally. Mental health is the emotional, the psychological, and the social well-being of a person. It is how we act, how we feel, and how we think, right? It is not completely physical health. They are two different things. Now, how we did think, how what a person do, we go react to her, and how we did feel up when it happens to us. So now, talking about those mental health issues around stigma for key population is that when the mental health of key populations are not really in shape, you see that they don't seek for services or they even delay uptake of services. I remember my colleague here had mentioned earlier the issue of delay, the issue of completely withdraw ourselves. You see that as then they go facility where they know they're comfortable, they might, if they go the first time, you know, go see them again. Or they might not even go when they hear stories from other key population members saying, oh, I went to this facility. This was my experience. Once the experience is negative, you see that's either withdrawal or that delay of even, and that worsen their health condition. And then let's remember that stigma affects key population, that at the end of the day, they begin to experience anxiety. They begin to experience emotional trauma. And remember, in the definition of mental health, we talked about it is how we feel, it is how we act, and it is how we think. So you see that there's this emotional trauma they deal with, there's this anxiety, there's depression, and some of them starts considering suicidal thoughts. You see somebody who you just tell that, oh, your result states that you're HIV positive, and the next thing, the first thing is that my word has ended. And then they are not getting that mental support. It is not just, facilities should not just offer physical health, but also consider mental health. Because a lot of times, if this mental health is not integrated into the programs that we offer for key population, there's this worse outcome in terms of service uptake for key population. And then going to your second question, you said, what's your second question again?
Okay. How does it impact their willingness to seek for help?
Okay, yes. So just like I was saying earlier, it is that there's the withdrawal. Key population no go gree come again for services. So it means that they now live with this virus or this stigma that keeps them away from service uptake. And that's as a result of the judgmental issues that they face from healthcare providers, from the society generally. I remember when we talk about mental health, it also has a component of social well-being of a person. Our environment, the communities at large, if they get that stigma from the community, they get that discrimination from community, there's this total withdrawal from the society. You just find out that there are some key population that no longer want to associate with other persons. And at that point, they are dealing with depression. They have emotional trauma. And then the next thing is that since the world doesn't want me, I don't want to be here. And there's this, oh, the only thing I can do is take up my life. So the important thing is that our healthcare providers, they need to be trained on how to provide non-judgmental services and how to incorporate mental health into physical health services that they provide for key population. And then be trained even around value clarification and attitude transformation, because it is your value is being imposed on the values of other persons. Meanwhile, you're supposed to be that healthcare provider that saves life, that is there to make sure that life is safe. They should be counting lives that are living rather than the death rates in our country. So it means that as a doctor, your first mandate is what? Provide life. You are there to make sure that at whatever cost is going to happen, to make sure that this life is safe. You have to do it. So it means that incorporating mental health into physical health services that you're providing to key population, and making sure that your values is not what you're, just like my colleague mentioned earlier, you don't impose your religious values on people. You don't that first welcome, that first communications that you provide for key population when they enter is like, hey, Alpha, what's wrong with you? What did they do you? How body? Oh, okay, your result. Oh, how are you faring? You know, there are times people come to pick up drugs, and all they are driven about is your refill, the drugs that you're going to take. Or you collect drugs, next person, collect drugs, next person. You hardly find healthcare provider who will say, how are you doing? Highest they'll do if you get issue, make sure say you call me. But your projection can make that withdrawal instantly. But if you are that kind of healthcare provider that sits down when your thing comes in and say, it is we that needs to deviate a means that we can be able to communicate with our patients. It might be crowded. You might now decide to do like a group welfare check. How are you doing? I think they do that a lot in antenatal for mothers. How are we doing? Do you have this problem? Remember, when you have this problem, you can call this doctor, you can call this nurse, you can call this doctor. Those kind of integration into the service that we provide for key population can really help how we navigate the issue of stigma, how key population project themselves in accessing services, how they relate, and the relationship is vice versa. Thank you.
Okay. So is in terms of support, what can you give us more specific examples of the kind of mental health support that is needed and the one that is available for key populations in access as relatively available key population?
Okay, thank you. So for the services we need in terms of mental health for key population, trauma-informed care is very important for key population. Be able to understand the type of trauma a patient is dealing with. Just like if you hear from their sex story, the issue of a sex worker is not the same issue with an MSM or a drug user. And then in each of these diversity, there's diversity. You will find a sex worker that is a drug user. Their issue is different from a sex worker who is not a drug user. So that trauma-informed care is very important when delivering, and then also a non-judgmental service. So healthcare providers need to be trained on non-judgmental. There's this say that as you come in to say that, oh, I just had an abortion. I had an abortion. My friend took me to this. My friend carried me go one doctor like that. No be saying a hospital, just say the doctor no you do abortion for people. Then do me this abortion. But for days now, still they get paid. The next thing you hear from the healthcare provider, Jesus Christ, small pikin like you, why you go? They see your age, your mates, they school. Before they now remember that, oh no, I'm the healthcare provider. They first become moral providers before they become healthcare providers. So, that's a judgmental. And you see that kind of thing. Yes, policing. You see the moment they come in, that key population leaves that place, it might not return again. That's if they even continue the service they keep.
Yeah, and that does definitely go back to tell
now
his own.
Exactly, friends that I no go that facility. Hey, this one. All you see the points where a community enters and my mother's friend is a nurse in this facility. Oh girl. Now they forget that there's this part where as a healthcare provider, there's that law that you have signed of confidentiality. Do you understand? But because he's my mother's friend, say, this auntie is a bit talk. If they come to our house like a bit talk, no, not going to try it. And it might be the facility that will offer the best service. But just that one person has made the service unavailable for multiple community members. And then in terms of the services that are available at the moment, of course, we have peer support in terms of support group services, but then how well are we navigating our support group systems? Who are the healthcare who are those story or lived experience peers that want to share their own story in terms of navigation, maybe societal pressure, family pressure, the healthcare facility? How were you able to navigate to be on care for this long? Are you willing to share, to also inform and support other peers who are struggling to navigate at the moment? So we have those peer support groups. We have even one-on-one. There are some that have found that interest in a particular person and say, oh, I see this person as a mentor who has been probably from a support group. You just find out that, oh, this person, I need to engage more. And this person is there to provide. And there are some even key population who are advanced, who are also knowledgeable, who are that well informed, who also provide those non-judgmental support for key populations struggling to navigate this space at the moment. So all of those services are currently available, and also expanding to make sure that we integrate mental health services into the programs that we currently offer, both as organizations and also when writing to donors.
Thank you very much. So, not only do this good work for some months now and they impact people, but it dey worry me. Una get any challenges wey so far una don face for this initiative as una dey work for we area for communities? Wetin be the challenges wey don try to prevent una from carrying out this work so far?
Okay, thank you for this question. Plenty challenges been there. First, when we start this work, we try to bring the key population to come for the sensitization. Say these are our work, and the people and the KP, they know they too trust people. Some people they think say, if I come, somebody go see me. You understand? So that has been a challenge to our work. And secondly, and we, our organizations, we are advocating for the health right of this key population. So many times we have been misunderstood. There was a time that we have to pause our work because we work in the north. The government is busy shutting down KP organizations. The KPs, they are on the run. Like, who are we implementing the project for? Is the KPs, and they are nowhere to be found at that period. So we have to stop. This has been a challenge to our work. And another challenge is the OSS staff that we are working with. They have their own policy. They have their own organization. So we invite them. Sometimes their bosses will not allow them to come. They will engage them in another activity, and will just be there only us without them. You understand? So this has been some of the challenges that we face during the work.
Okay, so can you share with us some persistent barriers to inclusive healthcare?
Yeah, definitely. So when we talk about inclusive healthcare, they refer to healthcare services where recognize differences that exist between us. Just knowing that human beings no be homogeneous group where everybody problem did the same, and so one size fits all approach is most times not the best. And so they talk about inclusive healthcare services where recognize key populations with their unique issues, their unique challenges, just like my colleagues here have shared. And some of these barriers, I think that our healthcare providers, first and foremost, they receive training to, like specialized trainings for healthcare for key population issues. And so it got very important if this is added into the curriculum, like the educational curriculum systems for healthcare practitioners. Like, how do you handle different issues, including key populations, young people, women? We just used to recognize that people are different with different unique needs. Of course, secondly, in our country, Nigeria, we get plenty laws, discriminatory laws, where they affect the key population. Some of these discriminatory laws are the reasons why inclusive healthcare is also a challenge, especially for key populations, especially where you're talking about threshold for handling drug use. Abortion is not legal in the country. It's the same-sex marriage for Abortion Act. There are so many of these laws that are discriminatory. That's kind of they affect how healthcare people also respond to the issues of key populations. I think another thing I go share on the issue of confidentiality. We don't trash this one plenty, so I probably just brush over it. But confidentiality is something also that is very important that our healthcare providers need to prioritize. How what's it called now? Patient rights, right? Like the rights of patients, the right to confidential treatment and care services, and so go just because this person come your distance for services, post-abortion services. This person has anal warts. They go say, oh, I know this person, mama. I can't even wait for next Tuesday. Well, they meet for their house. Even the mama they host next Sunday meeting. Yeah, make I tell her and all of that, because those kind of things just push key populations away from accessing treatment and services. What else can I? There are so many of them, but I think that these few are the ones that I'll iterate for now, because I think that we probably. But I'm happy to share more if there's some time.
Okay, thank you. We get some key recommendations if you give us for the health sector and for government to improve overall healthcare. As una don dey work, like say una don dey see many things.
Yes, like based on wetin Odi talk, it don't highlight some of the things. But during our period of intervention, wetin so also we develop action plan we for the community. We carry we give for the OSS. We come together. Even they said they believe among the action plan. So we come together. Oku developer. I will develop the action plan. And one of the things we could recommend be say, based on the research, we feel say if government or let's say donor go fit the support and a key population listing organization of who they provide where they serve them directly. If they go feel reach out to them to support their program, it could be much better for them to go far. Why they talk like that? As it do like this now, you also the OSS will be refer those our clients now they go and the massive uptake be the area of services. Now and then those our OSS people say they said they get support from another donor, which is the USAID. And with this new Trump administration now, it gets some services now where if you go there is not allowed. The no go fit get them again. So with a feel that one of our recommendations be say if donor or government still go fit, make them at least fit the reach out or support, not use the word support, organizations where they know say yes, they provide or they represent this key population. And again, another recommendation we will give again. Now, based on still our research, we discover okay, and we give the recommendation. Say moving forward now, at least maybe they design intervention with just like within ODB talk or within pandemic talk, we could they fit in within key population wants. Their specific needs. You will be from FS only for instance. Your services now waiting you need be that. Make the no generalize everything not put up for one place. Say that's everybody will need the same services. Just like I mean, like the harm reduction program I talked to, I feel like now something where just like what the nation about policies. So policies the way it also need those healthcare providers not to actually go beyond waiting the feet, offer. If government to go feel look into the policies just to ensure that key population are being treated equally when it has to do with health. I feel that it will take us a long way. It will reduce a lot of stigma and discrimination. It will reduce a lot of withdrawal, just like what Paddy said. So we just feel that these are recommendations. At least it will help. It will help for us to also do our work much better and to provide better services for
our committee members. Thank you.
Yeah, I also just want to add that the community they broad. This community we're speaking about is very broad, and communication they very key. One thing where I go also like to add as a recommendation, gender affirming care. Like when some people are intersex, you see them as they're just born like that with a biological definition. We know they waiting people they define as categorically male and female. So sometimes when you see a male, it's not necessarily like the person may not even be identifying as a male, right? And so affirming gender care in a care way, healthcare providers are learning to know that you address people the way that you respect people's pronouns, so give them that room, and those kind of services, give them the room to be who they are. Those kind of services can also help them to just be themselves and come forward for the services when they know that their personal dignity and personal identity, they're respected as well.
And I would like to add to say let there be collaboration between the organizations that deal with key population and the health facility. Any issues that they're seeing in their facility, they can refer to this organization, the consortium organization. Yes.
Wow. Hardy, what you mentioned some barriers to inclusive healthcare. Don't know if you could highlight a few barriers for us that are specific to related to mental health.
All right, thank you. So let me just add my voice to my colleague in terms of mental health. Some of those barriers are mental health generally is underfunded. Most of the times, even sidelined. So that's like a really stronger, and that's why a lot of work around mental health has been limiting, and we have very few trained professionals. And these few trained professionals makes it really expensive for people to even afford. Then look at key population again in general. So it's more like we need more trained professional in the system, and then biases among and providers as well. They tend to give probably wrong information or neglect or give harmful advices like, oh, you get comments from some healthcare providers or professional like, instead of addressing the health concern and including the mental health of the patient in front of you, you first of all want to bring your police in, you want to bring your morals. So at that point, that's not what the patient needs. So you see, that's already a barrier to how a patient would want to also receive the service that is. And also around policies, criminalizations, are there inclusive policies that really stress the need where a patient comes and the patient is provided mental health care alongside physical care? That's that. Thank you.
What recommendation would you have for the healthcare sector generally, the government and all actors to improve healthcare delivery in terms of mental health?
All right. Okay. So I would say that generally it's a total well-being of a person. It includes the mental and physical health. First is for us to kill our biases and commit to change. And then, as much as trainings are ongoing for healthcare providers, can we include VCATs, value clarification, attitude transformation, and human rights trainings for healthcare providers generally? And also, the use of affirming languages. And just like if you heard my colleague earlier, affirming languages really allow patients receive services, really shows welcoming of the patients into a facility, and then protecting confidentiality. As just as you sign those codes, can we maintain as much as possible? And if possible, recite confidentiality in various facilities aside the oaths that healthcare providers must have signed during their institution are passing. And also, I would say that let's see how we can track and address issues of discrimination, accountability, referrals, and all of that. Thank you.
Thank you. So, Odi, can you tell us some ways how individuals can contribute to societal changing societal attitudes?
I think that the first and foremost thing we say we need to educate ourselves. Like people need to educate themselves on how they interact with key populations, how we deal with key populations and their issues. Just trying to even understand, be empathetic about the issues of key populations they face could help us to even better understand, demystify some of those myths we put the carry for head, say, oh, these are the issues and all of that. And so this would also help people to be able to speak out against stigma and discrimination. So even if you see where somebody is being stigmatized or discriminated against, if you don't have to be the healthcare provider, just the fact that you're there for that presence, you can speak out and support. And also, speaking out can also help us to amplify the voices of these marginalized communities, what we talk about, which is key populations. I like the fact that they do IC materials to provide information, which I'm sure some of the only key populations that they share out. They also go to general public healthcare facilities and all of that. But I think that as owner, we'll continue to engage committee members, going to engage healthcare workers and other stakeholders. These voices will amplify, will continue to understand these issues that key populations they face. And by knowing these issues is a step to addressing these issues. You need to identify the issues first off before you're able to address them. So continue the research, continue to I would encourage people to continue to reach out to information organizations like the consortium members with the here, Teddy, Tara, Help Pro, and Husky Youth Initiative, right? And other key population-led organizations within the country to understand better about the issues of key populations they face. And most importantly, people should donate to the work that you're doing, right? Support the work that you're doing. Yeah. Funding is very necessary. Exactly, of course. Funding is very necessary. Like make a help to with planning money. You can consider what they do. And I would also encourage people, if you want to support this work, you can also reach out to these organizations on the volunteer basis just to learn more about what they are doing and to help. You go help yourself to even know better, change your personal attitudes as well as contribute to community building everything.
Okay, thank you. I believe we don't learn plenty things. Me, I don't learn. And we will watch never be here. We don't learn plenty things. We won't end our discussion here, but I want the same way just to join us now. I want someone like give final word, at least one advice to our mama, pikin, and papa them with the house. What thing they fit do on their own to help their own self and their community. Just one small advice from everybody before we close.
Oh, okay. The advisor of the people that let in everything you are doing, let humanity come first.
Okay. Humanity should come first in everything we're doing. Thank you.
Yeah, for me, it's just a short advice. Out there to people that watching us or hearing us, I believe that when we work together, we can, solve a lot of problems. So that's just my own advice today.
Okay, I want you to word from him a final word.
Okay. Final words is, first of all, just like I defined from the beginning, I say mental health, emotional, psychological, and social well-being. Meaning, mental health is a right. It's not a luxury. And key population should be treated with dignity, care, and safety. And as much as possible, let's prioritize mental health in physical health services. Let's find a way to integrate it at all levels. Thank you.
Thank you, Body. I go say make we challenge our personal biases. Like if you get personal biases, like your religious bias, your cultural biases, just challenge those stay away from that. Like, just learn to appreciate people, learn to understand the needs of people, and learn to know who people are and understand them and provide services where they meant for this people and things like that.
Our country people, una don hear this better gist wey dis correct people don bring to tell us how they dey help us for we area and communities to improve ourselves. We don hear how Tara, Hesky, Hepro and Teddy dey help key populations in various areas for Adamawa, Bauchi and Gombe to improve themselves and their health. Hope this talk will help all of us and we learn one or two things from her. We thank ISDA for providing this opportunity and supporting them to do the wonderful and ogbonge work wey they do for our communities. Next time, una join us for this same time as we go dey talk this thing. Thank you.